protection against injuries. The third most common injury in rugby is concussions. A concussion is a traumatic brain injury induced by biomechanical forces that are transmitted to the brain, either directly or indirectly. Symptoms associated with concussions are usually classified as a disturbance in neurological function with a lack of structural abnormalities. These symptoms impair function in the injured player and can have long-term effects, making concussions very dangerous, especially in a full contact sport. There's no guaranteed protection against concussions. Despite most athletes recognizing that a concussion is a very serious injury, multiple studies have sampled populations where over 70% of the participants say they would still play with a concussion. These players often cite reasons such as a love of the game, or you train your whole season for the playoffs. This becomes really dangerous if an athlete returns to play before the concussion is fully resolved. If the next injury the player gets is another concussion, it can have long-term impact on their cognition or increase the risk of developing chronic traumatic encephalopathy. Considering concussions are serious injuries that can have lifelong consequences, it's very important to have tools that can accurately assess concussions and their severity.
Half of all concussions have resulted in athletes reporting dysfunction, dizziness, and balance deficits. These symptoms reflect underlying impairment of the vestibular system, which is a complex sensory network that indicates self-motion, orientation, and is linked to gaze stability and visual motion sensitivity. Until recently, assessing the vestibular system has required expensive equipment used by trained clinicians, which aren't readily available for testing athletes on the sideline. Vestibular and oculomotor symptoms elicited with concussions, headache, dizziness, nausea, and fogginess, are now evaluated with the recently developed bombs, which takes only 5 minutes to perform. However, because it's a fairly new concussion screen, it lacks the research that other screens have. The symptom provocation of the bombs includes smooth pursuits, saccades, vestibular ocular reflex, vestibular motion sensitivity, and near point of convergence, in which an average of 3 distance trials is taken. Athletes being assessed rate the above 4 symptoms on a 10-point Likert scale following performance of each item. Over 60% of patients with concussions report system provocation on more than one item, indicating a low false positive rate. There is high predicted probability for utilizing bombs to detect concussed athletes. It's vital to look at athlete history for motion sickness susceptibility, migraines, anxiety, neurological disorders, and past concussions, as these can all be elicited using the screen. Otherwise, a baseline assessment may have abnormal values, but it can still be used in the absence of a baseline due to high sensitivity for concussion diagnosis. BOMS has high overall internal consistency of administration, using the same metronome speed and item order, and evaluation for both healthy and concussed athletes. Therapists involved with return to play must be trained in performing BOMS to help develop the appropriate recommendations using individualized methods. The most effective treatments include vestibular therapy and extended exertion therapy. If a sport involves dynamic movements, treatment should mimic those movements to provoke any underlying symptoms. Otherwise, they will go unnoticed.
The King-Devitt test is a frequently used method due to it being a practical sideline screening tool that is quick and simple to complete in a matter of minutes, and it can be administered by non-medical individuals. It is an accurate and sensitive indicator of concussion, and scoring is not affected by a noisy environment. This test measures the speed at which a player can complete reading numbers on cards presented to them, as well as captures eye movement to decipher whether neurological functioning has been impaired. Due to oculomotor functioning being reported as a primary discriminator of mild traumatic brain injury, this test is very useful. By completing a KD assessment, it can measure differential from preseason injury results in comparison to after an injury has occurred. That is crucial to take baseline scores in order to allow for future season comparisons. To perform this test, 3 cards are provided to the athlete, each with 40 single-digit numbers, arranged on the card in 8 rows, each consisting of 5 numbers. The amount of time it takes for a participant to read the numbers from left to right in an ordered manner, as well as the amount of mistakes made, is then recorded and used as baseline values. From here, KD tests can later be taken for those who may appear to have suffered head trauma throughout the season, to see if response times have become delayed.
Now it's your turn to try the King-Devitt test. Pause the video and time yourself to see how long it takes you to read the numbers. How did you do? The average time for an athlete is 51.24 seconds.
The KD test detects up to 80% of concussed athletes. Although KD test is easy to perform, it can be affected by errors of habituation and anticipation on the athlete's part. In addition, it is not 100% sensitive to detecting concussion, therefore it should not be done as a standalone test, but a complementary assessment.
The SCAT-3 is one of the main tools used today to assess for concussions in athletes. It contains multiple subsections consisting of symptom evaluation, cognitive assessment, and physical examination. The symptom evaluation is a portion in which participants subjectively rate their symptoms or lack thereof. The potential issue with this is that subjective experience can vary significantly depending on situational aspects. For example, athletes in competition may present with more symptoms on the evaluated portion than preseason athletes do, due to situational effects such as dehydration, which can also be associated with fatigue or headaches, both of which represent concussive symptoms. The SCAT-3 physical examination includes a modified BESS. The BESS is widely used as it is a low-technology, cost-effective test that can be done in most environments. Individuals being tested are required to perform 3 different stances for 20 seconds, each on a hard surface and a foam surface, with eyes closed and hands on hips. The stances include a single leg stance, feet together, and a tandem stance. Errors are tallied to a maximum of 10 errors per stance and are used to evaluate the individual's performance. Errors include opening eyes, taking hands off hips, moving out of position in any way, and failing to return to test position in less than 5 seconds. Studies have found that the BESS has moderate to good reliability. Some of these subcategories are reliable enough to be used in clinical assessment, while many, as well as a total score, are not. Therefore, it's recommended to use the average of 3 assessments to improve reliability. The lack of reliability is due to inter-individual differences when performing the BESS assessment, as perceptions of how many errors occurred can differ quite a bit between assessors. It is also hard to see errors in some of the subcategories. For example, if someone is standing on a foam block, it's hard to see if they're lifting their heel or their toes. Finally, BESS cannot detect balance problems after the 3rd day of recovery from a concussion, and it's therefore best used as a pre-screening tool.
The International Rugby Board strictly prohibits return to play on the same day of a concussion. The general advice is to go through a 3-week stand-down period where the player allows for symptoms to subside. The implementation of a graduated return to play protocol is used to help slowly integrate a player back into physical activity while being aware of their cognitive symptoms. The graduated return to play protocol has 6 stages. 1. Physical and cognitive rest until asymptomatic. 2. Light aerobic exercise. 3. Sport-specific exercise. 4. Non-contact training drills. 5. All-contact practices. And 6. Return to play. The player must remain at their stage until they are asymptomatic for 24 hours. If symptoms reappear, then they are descended to the lower stage. Using this protocol, the soonest a player can return to play after concussion is 6 days. Players may be non-compliant with the program if there's something motivating them to get back to the game faster. This puts them at a risk for prolonged symptoms, another concussion, or other subsequent injuries. The SCAT-3 test appears to be the best assessment to judge the severity of a concussion by looking at the physical and cognitive systems. This can also help determine the best return to play time when used in combination with the graduated return to play protocol. While the other tests have individual benefits, they are insufficient on their own, and multiple aspects must be addressed when prescribing concussions.